Good morning. Welcome to day three of Stroudwater Associates' sixth annual Critical Access Hospital Conference. Whether you've been with us throughout the week or are joining for the first time today, thank you for being here. At Stroudwater Associates, we work exclusively with rural hospitals nationwide. Our team includes former rural hospital CEOs, financial leaders, clinicians, operators, and strategic advisors who understand firsthand the real realities rural healthcare organizations are navigating every day. Throughout this conference, rural healthcare leaders and industry experts are sharing practical strategies, lessons learned, and approaches that rural hospitals are actively implementing to strengthen operations, improve sustainability, and better support the communities they serve. Today's sessions will focus on performance improvement, practice operations, survey readiness, and the operational and financial levers that can strengthen long-term sustainability for rural hospitals. We'll begin today, day three, with a session focused on how operational and financial performance directly influences the strategic opportunities available to rural hospitals. In today's environment, performance improvement is no longer simply a short-term financial exercise. It plays a major role in strengthening flexibility, stability, and long-term positioning. In this session, Wade Gallen and Claire Kelly, our two senior consultants at Stroudwater, will explore the performance improvement initiatives that consistently drive measurable impact for rural hospitals. Drawing from their experience supporting rural healthcare organizations across financial strategy, operational improvement, affiliations, and long-term planning, they'll share practical approaches hospitals are using to strengthen contribution margin, improve sustainability, and expand strategic flexibility. And with that, introduce Wade and Claire. Take it away.
Hey, good morning, everyone. Thank you so much for being with us today. We're excited to chat with you about performance improvement and how, in collaboration with strategic options, it can really lend itself to creating success and expanding opportunities for rural organizations. As Keith just said, my name is Claire Kelly. I'm a senior consultant with Stroudwater Associates. I specialize in all things rural strategy. I'm joined today by Wade Gallen, who's also a senior consultant with Stroudwater and who is our performance improvement nerd and finance guru. So why does performance improvement matter? Why are we talking about this today? Why have this conversation? So we'd like to kick things off with a poll. And the polling question is, how much lead time do you believe is needed for a performance improvement plan to really take effect? Is it less than 6 months, 6 to 12 months, 12 to 18 months, 18 plus months, or some impacts felt in each time period above? And we'll give folks about another 20 seconds or so to respond to this question before we close it out. And we've already got responses coming in, so thank you so much. Awesome. So right now we're at about 15% less than 6 months, 44% 6 to 12, 12% 12 to 18, 1% 18 plus, and about 29% some impacts felt in each time period above. Okay, so final numbers, 15% less than 6 months, 44% 6 to 12 months, 11% 12 to 18 months, 2% 18 plus months, and 28% some impacts felt in each time period above. What we would typically say is that depending on the performance improvement initiative you're after, there's some impacts are really felt in each time period above. You can do some earlier on and some that will take that 18 plus months to really start to see some of those effects. So Stroudwater wanted to dive into this concept a little bit more in depth, and we conducted a study on closed rural hospitals. And one of the questions we wanted to answer was, where is that tipping point prior to closure where those negative trends really start to accelerate and increase in magnitude? And we found that about 8 to 4 years prior to rural hospital closure is really where that tipping point starts to spiral out of control. The analogy I like to use here is the performance improvement gaps that are seen between 8 to 4 years prior to closure are campfires. You'll need a plan to make sure you're putting them out. You'll need to assign someone to help you deal with that plan and pour water on that fire, but they haven't fully spiraled into what we call wildfires, where they're going to take a lot more personnel, a lot more time, and a lot more equipment to gain and control over and be able to put out fully. So again, wanting to make sure you are addressing those performance improvement gaps earlier on than even you may think necessary, and you're understanding how those performance improvement gaps are looking over time, not comparing those gaps to just the prior year, but 3 to 5 years prior to really understand the direction of those negative trends and how they're occurring. The goal here is to increase your strategic options available to you and lengthen the runway. What you don't want to do is start to do performance improvement when your runway is so shortened that you have limited options available to you. Doing performance improvement only lengthens the runway that you've got in front of you and only increases sustainability for your organization. So if you take nothing else away from the presentation today, please take away this point that sound operations underpin all options, regardless of what strategic option you're after, whether it's to remain independent, whether you're in an existing partnership, or whether you're looking at a potential partnership. Performance improvement and sound operations are really the bedrock for creating a strong position. You want to make sure you know the risk of your organization and are analyzing that risk on a yearly basis. Use that risk to quantify and identify performance improvement gaps and set out plans to address those performance improvement gaps. Again, not just looking at the prior year, but looking 3 to 5 years prior and understanding those trends. Because again, doing performance improvement work will only improve the sustainability of an independent organization or increase your leverage with a potential partner or an existing partner. And with that, I'll pass it off to Wade to talk about common performance improvement initiatives.
Absolutely. Thank you, Claire, for that. And just to riff off what you were sharing a little while ago, I think something that strikes me, even as we look at the initial chart that shows kind of the timeline for some of the decline for hospitals and the performance improvement initiatives that could help, I think as we talk about all of these different initiatives, right, we'll touch on a few of these here. We've got some further comments around them, but as we talk about it, it really has to be a continual conversation with rural hospitals. We can't, as you mentioned, Claire, wait until we're on our last leg, so to speak, from a financial perspective. And an observation that we've had at Stroudwater, having come across a number of those situations, is you can never start soon enough. It's always better to start with something before you actually think you need a strong performance improvement plan. So it's really a continual part of rural hospital operations we're facing so many challenges right now in rural organizations around reimbursement, financial performance, the need to retain staff, so many different challenges. And again, this should be really part of a continual conversation. As we do performance improvement work for rural hospitals, these are some of the themes, and I don't want to make this seem like a comprehensive list of all of the opportunities available to rural hospitals. It most certainly is not, but these are some of the common ones that we found in our work with those hospitals. We have a revenue cycle improvement, 340B enhancement. This one is, I would argue, even more important now, given many of the recent challenges to the 340B program from a number of different fronts. So it remains incredibly important for our rural hospitals. ED optimization. So our emergency department continues to be one of the front doors to our organization as a rural hospital. And how are we leveraging that and making sure that we're offering a good patient experience, that we have strong really KPIs that we're tracking to understand how our emergency department is performing. I think this is incredibly key. Cost report optimization. While this is, I would argue, primarily for the critical access hospitals that we work with, in terms of the strategies that we see at least, there is a need to continually evaluate this for all rural hospitals. So that could be critical access hospitals, could be rural PPS hospitals, so community hospitals. There tends to be a plethora of opportunities within the Medicare cost report to enhance that reimbursement, swing bed optimization, and really growing the amount of services that we can provide in our hospital. The more care we can keep local, the better. And so we have found that for many rural hospitals, offering those swing bed services are incredibly important and can even help from a financial perspective. And then really looking at clinic designations. So for our rural hospitals that do have clinics that are a part of their footprint, really evaluating the designations that those fall under and whether or not there might be opportunity to consider alternative designations to perhaps take advantage of a favorable reimbursement structure on those to help us remain sustainable as an organization. So these are some of the key initiatives that we see. And I'll talk briefly about each of these in a little bit more depth in the next slide here. From a revenue cycle improvement perspective, I think the number one thing that we find is that we have to start with just measuring where we're at from a revenue cycle perspective. Do we have revenue cycle specific key performance indicators or KPIs? And do we have an effective measurement system? We can't just set a KPI and say we want to achieve a target of X number of days in AR if we're not able to effectively measure that from an organizational perspective. And maybe that's a poor example because that tends to be a KPI we encounter in many rural hospitals, but the point still remains that if we have a KPI of some kind, do we have the ability to effectively measure our progress against that KPI and calculate that KPI? Really setting targets, right? We like to refer to this as a measurement culture. And generally, when we're working with rural hospitals, it's easy to tell whether there's a measurement culture embedded within the organization, or if we're really doing more kind of ad hoc reporting where we feel the need to. We would argue that having a strong measurement culture is a foundational strategy for success for rural hospitals, and that's very prominent in the revenue cycle in particular. 340B, again, kind of coming back to measurement, this is going to be a major theme throughout the performance improvement initiatives that we have here is, do we understand the metrics that we need to track to know if our 340B program is performing at a level that we feel is appropriate, given our current clinic footprint, given our relationships with specialists in the area. There are a whole host of factors that contribute to what our 340B benefit is for the organization, but really tracking that, understanding things like our pharmacy capture rate. How many organizations have this embedded into existing reports or dashboards and are monitoring it on a consistent basis? And the other thing that I would add for 340B, and I would also say for revenue cycle actually, is we don't want to make the assumption that if we're outsourcing a certain part of this area, that we can set it and forget it and expect that the organization that we're outsourcing some of these things to is going to be able to maintain the level of performance that we expect as an organization. It takes a level of accountability, and revenue cycle and 340B are key areas that we oftentimes see from at least a measurement perspective being outsourced. And so we want to be mindful of that and make sure that we are tracking that as well, and we have good accountability there. Emergency department optimization. I talked about this a little bit, just making sure this is one of the front doors of our organization. Is it a good environment for a patient to come into? Is it accessible? Do we have strong patient care in this setting? How is our ED throughput looking? We need to be measuring that and monitoring that. The cost report. This is a key area that we oftentimes find quite a bit of opportunity. And as we think about that timeline that we pulled on earlier, kind of that, range of timeframes, the cost report can actually be one where I won't say it's immediate by any means, but it can be on the shorter end of that improvement timeframe because we can work with whether you outsource the cost report preparation or you do it internally. There are some options there to, if we know that we're missing out on opportunities, for us to take some immediate next steps, we'll call it. Swing bed development, this is really having a priority and a strategy for our swing bed program if we do maintain that program. We would argue that many organizations should consider this program, and it is nuanced, right? There's no one size fits all approach to rural hospitals. But typically, we find that growing a swing bed program can be a good strategy for success, and especially true for critical access hospitals, where we have some of that reimbursement tied in from Medicare. And then again, the designation strategy, really understanding what strategies are available if you even have a strategy. We talked a little bit about this in a session yesterday, but just the idea of understanding your clinic footprint, understanding the providers included in there, the specialties that may be offered in those clinics, trying to figure out, is there another designation that might be helping us retain sustainable care in the area? This is not just a financial opportunity for financial opportunity's sake. We're trying to maintain sustainable care in these rural areas, and we need to make sure we're properly taking advantage of the designations that are available to help us maintain that access to care. And go to the slides. So we've got a polling question here. So what is the biggest barrier to performance improvement at your hospital? It could be too little time, no consensus, expertise is required, costs of developing a plan, inadequate bandwidth, lack of staffing, all very relevant. And if you have maybe a different reason that's not reflected here, feel free to enter it in the chat. We'd love to hear from you. Okay. Seeing in the chat, lack of staff buy-in. Like it. All right, we'll give it another couple seconds here. Looks like we've got a good number. And we will end the poll now and see what we've got for results. The top answer is inadequate bandwidth at 35%. That's followed by no consensus on what is needed, which is at 16%. What was immediately following that? Oh, I'm sorry. Lack of staffing was actually the second one, and then no consensus on what is needed. Both of them were about neck and neck, and then the other reasons fell below that. So inadequate bandwidth is a very real concern for many of the hospitals that we work with. So as we look to, some of these barriers, right? And again, these are not the only ones. I think buy-in is incredibly important, as was alluded to in the comments here. Really, the implementation experience, we can talk a little bit more about that, but I think it's one thing to identify an opportunity, and then it's another thing to be able to effectively implement whatever that opportunity is and realize that opportunity. So sometimes that can be a challenge, especially if you have never gone through a process before. And that's one where, it might be worth trying to find some sort of external expertise to at least help guide you through, or as I like to say, phoning a friend, right? You are probably not the only rural hospital that has tried to accomplish whatever it is you're intending to. And so this is where we can really leverage perhaps our health networks, if you're a part of them, if you're in a system relationship, maybe there are other hospitals that have gone through a similar type of performance improvement initiative. This can be, it is certainly a challenge, but one that we can certainly strive to overcome there. Staff and leadership turnover, this is another one that we see quite frequently, right? If you have leadership for a hospital and they develop a very robust performance improvement plan, but then 6 months later, we have a whole new team, it becomes very difficult to build that momentum and even ensure that we have sufficient buy-in, right? Which leads to the next point. We may have had buy-in at one point in time, and now we no longer have that same level of buy-in. And that makes it very challenging to effectively implement these performance improvement plans. Inadequate systems, again, talking about that measurement culture, it's so difficult sometimes for us to find the systems that can help us measure how we're improving. Bandwidth, again, huge. We're all wearing multiple hats in our rural organizations. How do we prioritize performance improvement when we have so many other fires to fight on a daily basis? right? Which kind of leads to the lack of prioritization in a way, because depending upon where we're at and the importance of having a strong performance improvement plan, we really need to figure out how do we prioritize this within our organization, even knowing that we have all of these other fires that exist within our organization already. And then time constraints, again, that really comes to kind of a limited bandwidth there. Although sometimes it can be the actual performance improvement plan time frame just isn't going to work because of other constraints that exist, and those can vary dramatically. So they're very real challenges, and we would argue that it's really important for us as rural hospitals to be considering how do we overcome these. So recognizing the challenge, but also figuring out how might we be able to affect and overcome some of these challenges. And one of the things we decided to do as an organization was track some of the performance improvement opportunities that we found in working with rural hospitals. And we did this by looking at the estimated financial benefit of a given performance improvement initiative for 30 of the most recent performance improvement engagements we had taken place in. We've done many, many more beyond this, but we looked at the most recent subset of data that we had and tried to figure out, okay, what is the median financial improvement opportunity for these rural organizations, and what does that represent as a percentage of their net patient service revenue? And what we found was actually really interesting. We found that on the median financial improvement for a lot of these initiatives that are outlined there on the bottom, we have, for example, reduction in outmigration, we have revenue cycle improvements, the 340B program, cost report, et cetera. We found a median of about $1.7 million in improvement opportunities that were identified. Again, we have to be mindful and know that there's a difference between identification and actual implementation of these. But what was identified was fairly substantial, and it represented just shy of 8% of the organization's net patient service revenue. So I think that what we want to communicate with this is we believe a strong performance improvement plan is incredibly important and should be prioritized because it can have true benefit once we actually realize those opportunities as an organization. So this is really, to me, a calling to prioritize a strong performance improvement plan. And that's even if you're not even if you're in a very strong financial place. This has to be a continual conversation that occurs within your organization so that we can hopefully never get to the place where we need to have an urgent turnaround for our organization.
Thanks, Wade. So now that we've talked about different performance improvement initiatives, how does that lend itself to strategic options? And based on the strategic options that you're looking at, are there even more performance improvement initiatives that you could be examining? So if you're in an existing partnership or looking at a potential partnership, there are several performance initiatives that we haven't talked about, and we like to call these issues value levers. And it really articulates to an existing partner or a potential partner the value that you'd bring to their system or an organization. And we'll get into these value levers listed here in a moment, but the important part of this slide that I want folks to take away is that value levers in combination with the performance improvement initiatives that Wade just talked about can really change the profile of an affiliate to a partner. And when we've done a lot of affiliations and partnerships across the country, and frankly, what we've seen is that a lot of system partners, not out of ill will or malice, they just don't understand the rural value that you folks as critical access hospitals and rural hospitals can bring to their system. And what happens is rural hospitals end up being undervalued in a partnership. Being on top of and understanding and quantifying these value levers for your organization and being able to articulate them to an existing partner or a potential partner only gives you leverage and only puts you in a greater position of strength when it comes to entering into negotiations, whether that's looking at your existing partnership and saying, hey, here are areas where we can really enhance our partnership. Here's what we bring to your system. Can we talk about some additional things that we might want to cover? And when you're in a potential partnership, you want to make make folks compete for the privilege of being your partner, and identifying these value levers and being able to put them in front of potential partners and say, here's what we do for your system, what can you do for us, really helps put you in that position of greater leverage. So this is not, similar to Wade's comments, an extensive list, and this is not in order of importance. I want to stress that. But just to go through some of these, the first one we have is advantageous reimbursement methodologies. And I don't think this will come as a surprise to many, but it's really looking at, if you're a critical access hospital, you receive cost-based reimbursement. You can also have access to 340B, and there's certain clinic designation strategies that a system partner may not have access to, such as provider-based rural health centers. Home office cost allocations. So hospitals that maintain a system relationship and meet certain requirements may qualify for and include a home office cost allocation on the Medicare cost report and as an allowable expense. And this creates a cost sharing methodology that may allow a partner to allocate overhead costs incurred for providing administrative services to that critical access hospital, which allows for potentially enhanced system reimbursement. I will say for home office cost allocations, it does require a greater integration or a higher level of partnership, we'll say, where the finances are really tied together. So really the type of partnership that would meet this would be a sole member substitution or something like an asset purchase. Whereas if you're looking at clinical services agreements or a management agreement, that's not going to trigger the home office cost allocation. You're going to have that greater level of integration to take advantage of this. We've also looked at leveraged sites of services. So this is where you have really great if you have a rural hospital that's within driving distance to a potential partner or an existing partner. So if it's 30 to 60 minutes down the road, what can happen is you have folks that are lower acuity can stay at that rural hospital and be cared for locally, and you're preserving that closer to home access while that system is taking care of those higher acuity specialty patients that are going to need greater access to specialists than the rural hospital may be able to provide. What also it can do is it provides a relief valve for those patients at that system partner. So for example, folks that are swing bed patients and need to finish an acute patient stay and still in need of post-acute care can be transferred and come to that critical access hospital or rural hospital. And what this does is a couple things. It frees up a previously occupied bed at the system partner that now another high acute patient can fill. Additionally, it reduces variable costs of care incurred for keeping patients longer at that system partner versus the rural hospital. These last two, the value of attributed lives and the true value of incremental referrals, are extremely important and very regularly overlooked by a lot of system partners. So the value of attributed lives in a primary care base, I think we can all agree that a primary care base and a strong primary care base at that is really the lifeblood for a lot of critical access hospitals and rural hospitals. That referral network that comes from that primary care base is really what can have a hospital thrive or die. So systems really want to take advantage of that primary care base because they realize this and understand that that referral flow can be really important that comes out of those attributed lives in that primary care base. Talking about that referral flow, the true value of incremental referrals, we fundamentally find folks don't realize or quantify. And what you can do is you can create an estimated contribution margin benefit from a change in referral patterns as a result of a partnership. So for example, if a rural hospital is in an area that has 3 systems within driving distance and transfers for high acuity patients, and that rural hospital decides to affiliate with one of those system partners, that referral pattern of where you'd have folks going to all 3 is most likely going to change, and there's going to be more folks going to your system partner and not to the other 2 competing systems in that area. That change in market share and that change in referrals has concrete value and financial uptick for a system partner, and making sure you're able to quantify that and put that in front of your system partner is really important. We were working with a client in the Midwest who had an existing partner, but really wanted to come back to the negotiating table, and they didn't think they were necessarily being treated fairly by their system partner, and they wanted to relook at their partnership. And we got to this point and we were talking about incremental referrals. And someone in the audience raised their hand and said, I've pulled up our Excel file of ED transfers pre and post affiliation. And the results were staggering. It was close to a 4 to 5% shift in market share from folks that were just transfers out of the ED that added substantially to the bottom line to the system partner. So again, making sure you can articulate this and speak to it to your system partner or to a potential partner about these value levers is extremely important. All right, and with that, we'll get to our third polling question. How likely do you believe it is that your hospital can avoid closure, conversion, or partnering from an adverse position with an actionable performance improvement plan? Very likely, somewhat likely, not very likely, very unlikely, or unsure. And we'll give folks a couple seconds to respond. We've already got some results coming in, so thank you. Right. A few more seconds here. Awesome. Okay. You can go ahead and end the poll. So 48% said very likely, which is great. 30% somewhat likely, 3% not very likely, 7% very unlikely, and 11% unsure. So let's talk about kind of the three most common strategic options. What you'll notice about all three options is that performance improvement is a part of all of them. Whether it's option one, you want to remain independent, continue to serve your community as an independent hospital, lengthen that runway and create sustainability for your organization, continually working on performance improvement, continually monitoring the performance gaps that your organization has to really enhance your market position, your operations, your cash flow, so you're able to reinvest in your asset base and provide greater access to services is super important. For option two, it really is getting after performance improvement in combination and a parallel track with exploring potential partnership options and taking advantage of those value levers that we just talked about. It has all the benefits of option one because you're still doing a performance improvement plan. But additionally, what happens is because you're running a partnership process, competitors are, quote, frozen in place, meaning they're coming to the table and competing for the privilege of being your partner. They're less likely to make competitive inroads when they're trying to charm you and bid you and make sure that you're picking them as a preferred partner. So you're really freezing that competitive nature. Additionally, with those value levers and being able to educate your system partner or potential partners on those value levers really helps with negotiations and enhances your ability to negotiate on commitments to services and workforce, et cetera, because you have those quantified. Option three is looking at performance improvement initiatives in conjunction with existing partnerships. And again, it highlights everything from option one, and you have the enhanced leverage that's labeled in option two. What we would say here is that the key with option three is starting with low-hanging fruit, starting with things that are easily agreed upon by your existing partner and yourself, such as making sure you're doing that leveraging sharing of patients appropriately, making sure that you're taking advantage of swing beds where folks can come and be at the lower acuity critical access hospital where your beds are filled up, and open up beds of higher acuity at the system partner is a win-win. Building that trust, tackling that low-hanging fruit first, really can set the foundation to start to tackle some of the harder issues, such as the incremental referral contribution margin conversation, as well as things like the home office cost allocation and if that's being calculated correctly. So really wanting to lay the foundation and build that trust is crucial for option three. So we have a case study to look at where we've done a bunch of this, where we've not only mirrored performance improvement initiatives that Wade has identified, but we also looked at some of the key value levers that we discussed. So we worked with a client that was about a $12 million net patient service revenue hospital. They had a very shortened runway where they had limited options available to them, and they were very worried about avoiding closure, and they wanted to find a potential partner. And so we started working with them immediately and identified a couple key areas for improvement being identified in the top left corner of this slide, looking at swing bed opportunities, a 340B opportunity, a cost report opportunity, and then identifying what a low estimate for the home office cost allocation would be versus a high estimate. And we did this for each potential partner that they were exploring affiliating with. What we found is that on a conservative level, the hospital needed about $3.6 million in required investment. We assumed 100% debt financing and 40% cost-based reimbursement. And we found that through these different performance improvement initiatives, not only would the hospital be able to fund its required investments, but it would be able to increase its operating performance by about $670K annually. And this is reflected in the net change in operating performance low estimate below. You see it never drops below 670K. The important thing to remember here too is all of these initiatives required really minimal investment from a partner aside from completing the affiliation process and negotiation of a pharmacy contract for the 340B opportunity. There was an opportunity that was identified and they just needed another person, another entity to help them with that. So again, things that they could take advantage of that really didn't require a lot of lift from the system partner, which is beneficial to the system partner and makes the critical access hospital and rural hospital more attractive. Additionally, not included in the analysis in the previous slide, we looked at the incremental referral opportunity for a partner from this critical access hospital. And because this system partner that they were looking at affiliating with had market share in their service area, we could identify, okay, based on our analysis of where referrals are going, we can see an uptick of potentially 2.5% on a conservative basis, where that if that should these two organizations affiliate, that would be the referral market share change. Based on that 2.5% uptick, the contribution margin for a potential gain of that 2.5% market uptick would be about $1 million. So again, identifying these value levers and performance improvement initiatives, quantifying them, and showing them to a potential partner was really beneficial for this client. And they affiliated with a regional referral center in their area, and it's been a really positive relationship, and it's been going really well. They're still a critical access hospital. They've maintained critical services for their organization and are continuing to serve their community. And with that, I'll pass it off to Wade for our key takeaways.
Myself off mute there. Thank you, Claire. So some of our key takeaways, which you can see in here. So a strong performance improvement plan. It's an asset, of course, and especially, so I would say one of the key takeaways is it's good to have a strong performance improvement plan, regardless of whether or not you're considering some form of partnership opportunity, but it can be a very strong mechanism to help as you are thinking through those partnership opportunities if you are in that situation as a rural hospital. So really, it's a very important piece of the conversation at every stage throughout the kind of life cycle in terms of partnership exploration for you all. Go to the next one. Let's see. Yeah, substantial financial benefit. This is what we referred to back when we looked at the slide, broken out by different performance improvement types, where there's some strong benefit to pursuing a performance improvement plan. And again, this isn't limited to when you are in financial distress or if you do end up in a place of financial distress. This has to do with at any point throughout your journey as an organization. You will have increased options if you're able to realize some financial and operational performance improvement opportunities. That's one of the things that we consistently hear when we're working with rural hospitals, speaking with everyone from senior leadership to board members, is really a desire to maintain options, I think is the best way to put it. That option could be some form of strategic partnership, but we want to be in a place where that's not the only thing we have to do in order to survive from a financial perspective. And it's important to address the barriers. We can recognize them for sure, but I would also encourage that in the effort of focusing on what we can control, how can we potentially address those barriers that would impede us from doing some sort of performance improvement work? And it doesn't have to, we also don't have to overcomplicate it. We can have fairly simple, uh, uh, the implementation might not be simple, but the ways that we develop a performance improvement plan and the ways that we track how we're doing on that performance improvement plan doesn't have to be incredibly complicated. We can simplify for sure. And then, combined with the value levers that Claire just talked about, performance improvement plans can really benefit you as a rural hospital and any potential partner that you might be looking to or having conversations with. And it gives us the opportunity to positively influence some of the terms around what any potential partnership might look like. So again, really a strong plan is a key asset no matter where you are in kind of the partnership exploration process. And it can really open up many more opportunities for you if you're able to identify and also realize some of these opportunities. And here we have some of our contact information. We'd love to, open it up for some Q&A and give you all a chance to ask questions.
Thanks very much, guys. As you, Wade said, we can open it up for Q&A. If you are on Zoom, if you can't find the Q&A, it might be under the More button, and you can add it right into there. Let me just see what we have here. So we have a question on swing beds. We are a call located in Southwest Arkansas. We have an internal target of or percentage of business on med-surg unit that should be swing bed. What goal do you recommend for cause for swing bed as a percentage of your ADC?
That's a good question. I don't know if I would have a single recommendation in terms of a percentage of your total inpatient census related to swing bed. We typically recommend and utilize a benchmark of roughly 3.0 average daily census per 10,000 population within your service area. It's again, one size does not fit all, so you can think of it more as a diagnostic to see where you're at. We have critical access hospitals where they're basically their entire census is swing bed. And then we have others where it's split more 50-50. And that doesn't mean that one is going to result in greater success than another. I think it really depends on your situation. But if you're looking for a benchmark to utilize, again, we look at it and evaluate, a 3.0 average daily census per 10,000 population within whatever you consider your service area. And so hopefully that helps.
Another question was, what was the end for these percentages? How many participants? And I'm just curious. I'm not exactly sure what slide that was.
Would it have been the one where we discussed the total financial benefit, or is that related to the polling questions?
I bet it's the financial benefit
Probably the
slide.
financial benefit,
Okay.
yeah.
Yeah, so for that one, we looked at 30 organizations that we had worked with in the past. I believe it was 2 years. And again, this was a sample size of the larger number of performance improvement engagements we've looked at. And one of the things that we wanted to do to reduce the risk by utilizing that median instead of an average of some kind, it reduced the risk of some sort of scaling. So we've worked with a range of hospital sizes and types, and we didn't want that to result in an inflated improvement opportunity figure. So we stuck with that median percentage to alleviate some of that. But we're actually in the process of updating that to include a greater sample as well.
We have another question from Blake. Question in regards to common performance indicators. What KPIs specifically do you recommend having for tracking and trending revenue cycle? He gives the examples of 340B optimization or ED optimization or cost report optimizations.
So is that specific measures to track in each of those different domains? Is that what the question was asking, or was it revenue cycle specific?
I think it's revenue cycle specific. Let's see here. Yeah, we're tracking revenue cycle.
Okay. Yeah, there are a host of measures, and I will not try and cover all of them, nor do I think that I would be the best person to try and cover all of them. Some of the things that I'll offer, some of the things we track and we look at when we're working with hospitals in this space. I think, days in AR is a really relatively easy one to track that we would hope that most organizations are monitoring. And so, days in AR, that's a great metric that we found. If you're able to track something, and this is becoming more and more relevant, I think, as we see the prevalence of high deductible health plans, responsibility falling more on the patient than perhaps from an insurer perspective, is really a point of service collections rate of some kind is a really important KPI to track from a revenue cycle perspective. And one of the other ones we're seeing, and these are broad strokes, right? You can get really nuanced and have even multiple ways to measure these, but also something in the form of a denial rate, because denials from commercial payers and other payers are becoming more and more of a challenge for rural hospitals. So some way of understanding your denials, and not just as a total number, but as a percentage of. So that way it gives you a sense of how you're doing there. There are so many other metrics that we could go into. One of the things that I know the Healthcare Financial Management Association, or HFMA for short, they have a MAP keys, which is specific to revenue cycle. I'd certainly recommend you take a look at those and see if there's any value that comes from that. But those are some of the ones that tend to stand out when we're doing our performance improvement work.
Another question is the 3.0 per 10,000 population benchmark derived for total census of inpatient plus swing bed?
That would be swing bed specific.
Okay. And then another question is, how are you using AI in performance improvement? My hypothesis is automate instead of redesigning.
So I'd love to know more what specifically they're talking about automating, but I would, on a surface level, I would agree that we need to figure out a way to leverage AI in terms of performance improvement. We're already seeing it significantly in areas like revenue cycle. In various aspects of revenue cycle, we're seeing different tools that are based in some sort of AI, and I think that that's going to continue. But if I'd love to better understand the comment around kind of redesign versus automate.
No, there's a follow-up here. So it's manual review of documentation using intelligent automation.
Yeah. Yeah. I don't know, Claire, do you have any thoughts on that, or looks
Yeah,
like
we're
you?
seeing that some of
Okay.
that in the provider space when it comes to note taking and helping providers chart faster. And I think AI can be, if used appropriately, and obviously as hospital organizations with PHI, it's really important that you are in a closed, secure loop with AI. Anything when it comes to any statistics or anything about your organization, but are starting to see it really be used to help folks update, tracking and being able to better report out faster on performance kind of metrics. I'm for sure starting to see that. But because it's so new, a lot of organizations haven't fully implemented it yet. So we're just really starting to see that come online.
Another question, with Medicare Advantage rapidly increasing, how can cause overcome the lack of a year-end settlement with MA plans? Should leaders aim to treat the cost report like a tax return, aiming to keep it as close to zero as possible year over year?
I have different thoughts on that, and I'd love to connect individually with whoever asked that question. I would say I don't know if that's always necessarily the right strategy. However, to the general question, I would say we want to be strategic about if and when we're requesting interim rate reviews from our MACs. Some of it is done or initiated by our MACs, but to the degree we have the ability to request that, I would say the first thing, and this is something that I don't see nearly as frequently as I would like, especially for critical access hospitals, is some sort of model in place that you are using on at least a quarterly basis to understand how your costs, how your revenues, how your volumes are impacting what Medicare may owe you or what you may owe Medicare, when you go to file your annual cost report. I think that that's the very basic kind of blocking and tackling exercise that I would encourage every CA to do. And then once we're able to establish that baseline, then we can start looking at where are we projected to be from a Medicare perspective, and how do we want to think about, again, requesting things like rate reviews so that we can capture our rates in the form of a rate letter from our MAC to then provide to our MA payers. I'm not saying that they're going to always follow it exactly, but we so to answer the question, baseline, make sure that you have something in place to track where you're going to be from a Medicare perspective each year. And the next phase of that would be looking at things on a consistent basis throughout the year to understand if it's worth requesting that rate review. And then the third phase of that would be, once we do have our rate letters in hand from our MAC, making sure that we're communicative of that with our MA payers.
Another question, our current performance improvement focuses on department reporting, but I don't see the needle moving. Is best practices to focus on the projects you shared, like 340B, KPI for revenue cycle, versus departments reporting on blood performance improvement, temp logs, et cetera?
I think the question, what I'm hearing, is one of prioritization of what plans we should be using. I don't think that. I'll be very honest. I have a financial background, and my kind of brain automatically skews to what is the highest dollar impact performance improvement plan that we can put in place. That being said, that's not always. You need to be considering the quality side of things as well, because quality is a huge part of us remaining sustainable in the long term. So I guess I don't know. I'm not sure how I would answer that specifically, but I would say both are important. And I think we do need to have a sense of what are the most meaningful performance improvement plans, from whether that's a quality perspective or a financial perspective. I think we need to be aware of that and make decisions around what we choose to prioritize.
I would also add to that from a competitive perspective as well. So if you have folks in your area that are competing with you for services, making sure you're monitoring those services in those departments too is really critical.
Good. Any other questions for the Q&A for the panelists? Please feel free to add. All right, I'm seeing none. Anything else you'd like to close out with, guys?
Thanks so much for everyone's time today.
All right, good. Let me get back to my script here. So thank you, Wade and Claire. That was an insightful discussion around the connection between performance improvement and long-term strategic flexibility. So as a reminder, when you exit today's session, you're going to receive a brief survey pop-up, and we greatly appreciate the feedback. It'll take you less than a minute to complete, and it really helps us to continue improving the conference programming for next year. So if you'll be joining us in our next session, we'll begin at the top of the hour. To join, once you exit this, return to the conference lobby and then select the next agenda, the next session from the agenda. Our next session is called Practice Management in Rural Settings, High Impact Fixes for Immediate Improvement. Focuses on practical operational strategies rural practices can implement immediately to improve performance and patient access. That's it. Thank you very much.
Thank you.